so what do we notice about him first? Case study number 1. Yeah, he's a skinny little man. BMI of 18. What else has happened with him? He's recently discharged from hospital with pneumonia. He's on steroids, he's on Flexitide. What else is he on? Oh, Jeff's got my copy, so you'll have to tell me.
He's on short-acting anticoagulant.
So, yep, he's on Atrovent, Flexitide and Respigen, PRN. I'll read it out. 65-year-old man with poor exercise tolerance on Atrovent, Flexitide and Respigen, recently discharged from hospital after pneumonia. Okay, any flags there? For considering Jeff's talk about biomarkers and Flexitide and pneumonia and things like that. If you have a look at his spirometry, his FEV1 is 18% of predicted. So does he fulfill the criteria for prescription of a long-acting muscarinic antagonist? Ages ago, yeah. And do we take tiotropium or glycopyrronium and Atrovent at the same time? No. Okay, so you're going to make some changes there. What about the Flexitide?
Because the eosinophil count is in a grey zone, I probably would stop it.
Okay, so I've added on there that his eosinophil count is 0.3.
I think that's a grey zone one, and Sammy Souza's published a paper showing that of all inhaled steroids, Flexitide's 2.1 times more likely to cause a pneumonia than other inhaled steroids. So I'd take him off the Flexitide because he's just had a pneumonia. But I might put him on a little dose of another inhaled steroid because I think he's still got 0.3. It's in that intermediate zone. You'd be a little bit nervous about suddenly stopping it. But I put him on a lower dose of something else.
Isn't that just a dose-related thing because the Flexitide is more potent anyway? Couldn't you just give him a low dose Flexitide?
That's a good question. He adjusted for that in his analysis. And people think it's because of its lipophilic properties that it may be more likely to cause bacterial proliferation of pathogenic bacteria that are resident within the airway. So there's a lipophilic area just within there, so that's why it hangs around for 12 hours. That's why you need a lesser dose. And it's probably got more to do with the fact that it hangs around the airways for longer, and if it's not wanted or needed there, and there are bacteria there, it may create more side effects than inhaled steroids that are more rapidly cleared from the airway, such as budesonide or beclomethasone.
But we tend to give that BD, shouldn't we be giving it a lot more frequently than budesonide?
You could argue that. It's only more recently that the pharmacokinetics have really been studied because we're looking at really, really small doses of steroid. So it's actually been quite difficult to study. It's only in 2011 that we've got good quality information that's come through that actually shows that BDP, strongly protein bound, races out of there in 2 hours, it's gone. Until 2011, we didn't know that. And we now know that fluticasone hangs around a long time, not only in the airways, but also in the peripheral systemic circulation as well. So I think it's just, there's no guidelines are coming out saying don't do it. There's increasing literature emergency that says, whoopsie, watch out. And I think particularly in the COPD population, the one we just highlighted here, I'd change it on to as what I would call a safer inhaled steroid. I wouldn't stop it because it's right in that intermediate range, yeah.
Okay, so this guy actually was discharged from Jeff's team and who had changed the management from when he had been previously in with pneumonia, and he did put him onto a low dose of Cuva. If we go on, he's short of breath after walking 20 metres, and his sats are 90 to 91% on air. So he's just been discharged from hospital with pneumonia. So would this fit a picture of what you'd be expecting to see with someone who's got a ratio of 30% predictor? I think so. He's just come out of hospital. He's definitely not back to his baselines and things. His 6-minute walk test, his resting sats are 93%. So in between leaving hospital and coming into rehab, his resting sats have gone up a little bit. So he's recovering a bit. But his lowest oxygen sats on his 6-minute walk test were 82%. And his 1-minute recovery was 88%. What do you think about that? Do you think he needs some time in rehab? We'd be pacing him. We'd be, if he's just had a pneumonia, we'd certainly be looking for some more improvement. He had walked 239 metres with 2 stops. would actually also fit his general condition, but we would be wanting to see some improvement. So we wouldn't necessarily rush in to put oxygen on him or get him onto ambulatory oxygen, but we will be definitely keeping an eye on him during the program. If his SATs were dropping that low, we might consider exercising him on some oxygen so that we can get an optimal benefit. But we'd certainly be wanting to have a look at follow-up 6-minute walk test to see what's changed and what's improved. Any comments on that, Sarah? Yeah. And what about future management? Can we talk about the BMI? Yeah, I think dietitian referrals in order. And often, you know, we'd often be talking about dietitian referral before rushing to just throwing him onto supplements. You know, sort of find out what he's actually doing. He could have lost a bit of weight recently with a pneumonia. He could have lost his appetite because he's been so sick. So certainly maybe some sitting down and some nutritional advice and then on to dietitian. And into the future, well, we'll be looking at advanced care planning. You know, how was this hospital stay for him? What's going to happen next time he comes in? What are his goals? What are we looking at in terms of management? And certainly socially, and in rehab we do this. How are you managing your activities of daily living? Do you need home help and stuff? You know, if he's gotten by with only Atrovent prescribed with a FEV1 of 18% predicted, you know, how long has this stuff been going on for, and is there some improvements we can make? Does anyone else have any comments on that?
What stage would you consider airway treatment?
I think if he had a chronic productive cough and we thought that the bronchitic symptoms were interfering with his lifestyle and he was having difficulty with clearing it, I think probably at the moment we don't have enough information to really truly guide us. But I would sort of tend to reserve it in this situation for people that are having frequent exacerbations despite our best efforts. And maybe that's a group that you might consider it in.
And he would probably have been on it in hospital, considering...
He would have had it in hospital.
Yeah, he would have had it for at least a few days in hospital. Does anyone have any comments about that?
Is the lung capacity, is that smaller serial enough to reassure you there's nothing to worry about, or would you need to... I've got recently left...
He's had a chest X-ray. He's got follow-up in outpatient clinic, and they've put him onto serial chest X-rays just to check on the left upper lobe opacity. So he's got that under. He'll have that in full clinic follow-up, and they'll see whether that is resolving.
I think it's improving, but our traditional way is, unless we were really concerned about it, follow up in 6 weeks. But in somebody that's got underlying COPD, it sometimes takes upwards of 4 or 6 months for it to resolve. But they're also a patient population at increased risk of lung cancer, so we'd have a lower threshold to do a CT scan if we were really concerned.
Okay. Our case study 2, does anyone have any questions about this one? Yeah. No, I actually said what would you be considering in her differential diagnosis, and it's actually on the front page.
I haven't actually seen it. Would you mind reading it out?
Yep, so Jeff, do you want to read it?
This is case A. Discharged from Middlemore Hospital, infective exacerbation of COPD, referred to pulmonary rehab from the ward, 45-year-old woman, BMI is 25, history of giant bullous disease, first diagnosed 1990 at the age of 20, followed up for 4 years with x-rays and lung function tests, and the patient refused further follow-up, 20-pack year smoking history, stopped 7 years ago, chronic urticaria, diagnosed by immunology, stress incontinence, chronic cough, GORD, oxygen saturations 86% at rest, apical breathing pattern, MRC score high, 4 or 5, and on Ventolin, 2 puffs daily, Serotype 125/25 2BD, Spiriva 18 micrograms Mane, Flixinase nasal spray, and omeprazole.
So if you didn't know that she had giant bullous disease and someone came in, is there a lung function test on that one?
There is on the back here.
Yeah, lung function?
Lung function, FEV1 was 1 over FVC 1.82, 33% predicted for FEV1.
So if you didn't know that this lady's got giant bullous disease and she came in with a young age, severely impacted with what looks like COPD, sort of outside the norm, what would you be thinking about? Alpha 1, yep. If I say she's Maori, would you still be thinking Alpha 1? It's a Caucasian genetic. It's attached to Caucasian genetics rather than Maori Polynesian. What else could you be thinking about? You'd be doing some smoking history, marijuana use. Yeah. Would you be taking quite a careful smoking history of her? So this lady's never smoked marijuana?
Never.
Never. And in actual fact, one of the things that alienated her, literally alienated her from healthcare, is that she was diagnosed at age 20 with giant bullous disease, and every medical professional that saw her said, "There's nothing we can do about you, will you stop smoking marijuana?" And when she said, and at that stage she'd never smoked, she said they told her that she was a liar and to stop lying. So she basically has rejected all medical care for 20 odd years until she turned up. And when she turned up, her posture, we talked before about using your senses and looking at how people stand. I've never seen someone with a more erect posture like that. And if you look, I've just shown you, there's a couple of slices of one slice of her CT on that. And when you look at her CT, she's just air all the way through here. So we sat down in clinic. I said to her,
It's a rare syndrome.
yeah, it is. Jeff, you don't usually see it that young, do you?
What's that?
The giant bullous disease.
No. It's she's been particularly susceptible to basically parenchymal lung destruction presumably from smoking. But if you look at her lung volumes, her residual volume is 190% predicted, so she's hugely hyperinflated. And it's thought to be that that's as a consequence of probably trapping of air in those bullae with increased positive pressure, and therefore it impacts negatively on the surrounding lung. So she's hugely hyperinflated. Yeah.
And she had a chronic cough. Her cough was so bad that I think I put a comment on her spirometry. I could only do one blow, and basically she'd cough for the next 10 minutes. She could only walk a very short place before she was coughing again. So I said to her, I did ask her the question about smoking marijuana. I said, and I was very gentle. I said, by the way, I always ask all my patients what they're smoking, and she said, "Rah." And I said, hang on, just simmer down. They would have asked you that because this is quite typical pattern for people who have a history of smoking marijuana. So I'm not getting at you, I'm just making a statement. And then when she told me that that's why she had not gone to doctors for years and years and decided to smoke after that, I said to her, well, actually, there is a potential, we can do something for you. And lung volume reduction surgery. So have people heard about that? Jeff, do you want to talk about that?
So did she have lung?
She had endobronchial valve
she had
placement.
bronchial.
So she's had them on one side, and that's the result of this X-ray.
So lung volume reduction surgery is being performed, it was historically performed by a thoracic surgeon in America, and interestingly had very good results, but about a 50% post-operative mortality rate, so it's sort of not hugely good unless you actually survived, I guess. But in the 1990s, because of the long waiting list for lung transplants, the thoracic surgeons began selecting out people who had hyperinflation and basically taking out resecting out the very damaged lungs. Like this lady's obviously got bullae, particularly in the apical segments. And if it was done in the hands of surgeons who were doing transplants, they ended up with very good post-operative results, not only in terms of improvement in quality of life and in lung function, but also they only had a post-operative mortality rate of about sort of 2 or 3%. And having published that, all the other thoracic surgeons around America and the world started doing it, and we started seeing 50% post-operative mortality rates again, because these people are usually very sick, and they need to be looked after in a facility where they get excellent post-operative care. But even despite all that, it's a big procedure to go through, and so an American company developed one-way valves that you can insert endobronchially into the airways. It seems to work best in patients who have upper lobe bullae particularly, and also importantly if they've got their fissure intact between the upper and lower lobes on a CT scan, because it's that group who who are less likely to have collateral supply through very small airways from the other lungs. So what you do is you put a one-way valve in and it deflates it. They can get air out of that lobe, but it doesn't go in when they take a breath in. So effectively what happens when you put it in is the upper lobe is looking like that's very hyper-expanded, and it comes down and reduces in size. And particularly if you get that effect, you'll have an improvement in FEV1 by about 0.1 to 0.6 or 7 litres, depending on how much deflation they get, and not surprisingly improvements in quality of life and exercise capacity.
So the sheet I just handed out now, she's so far had 3 valves placed on her right-hand side, and you can see already how her diaphragm came up basically immediately, and her oxygen sats improved, I think it was 86% to 96% while she was having bronchoscopy, actually having the procedure done. She's quite funny, she's walking around the gym now with like that, slightly lower, because you physically see the reduction in volume on that side, and she is looking forward to having valves placed on the other side as the DHB budget allows it. But she's already had she's had a decrease in her chronic cough, a marked decrease in it. She only has about 2 spasms per session rather than continually, and she's got more energy, she's managing a lot more, so all round incredible improvement in her life. Any comments on that? So just as I'm thinking a little bit outside the square, okay?
Marijuana lung, Robin Taylor made a submission when they were trying to legalise marijuana, showing that, I think, and Richard Beasley has done some data as well, which shows that one joint is probably equivalent to 20 cigarettes, and in terms of its effect on lung function. And then we published first series on marijuana lung, which was upper lobe distribution with it being very peripherally distributed. So probably somebody's got hold of her at Middlemore and said she looks like that, but in fact she doesn't look like a marijuana lung. Because,
it wasn't at Middlemore that we alienated her. It
Thank
was the one down the road.
Us. Yeah, okay.
They just kept doing lung function tests and said we can't do anything. Yeah. Okay, any thoughts on the third case study? 52-year-old Polynesian man diagnosed with OSA in 2011. His apnea-hypopnea index is 85. So that means that his airway blocks off 85 times every hour, every single time he goes to sleep. Okay, so that's more frequently than every minute. Okay, so you wonder why these people walk around like. He'd had 4 motor vehicle accidents before he came to sleep clinic, and his lowest oxygen sat on his polysomnography was 67%. So he's been treated on CPAP since he was diagnosed, and he's using it all the time. He's morbidly obese with a BMI of 54. He had a pneumonia in 2013, and that was the first time that a diagnosis of COPD was applied to him. He was started on Atrovent and Ventolin at that time. Now, and he was originally referred to pulmonary rehab from sleep clinic because there's a lot of overlap in us nurses and what we do. So, my colleague felt that he needed to lose a bit of weight, and so she referred him to pulmonary rehab. Now, when we went into his smoking history, he stopped smoking 20 years ago. At the time of his assessment, spirometry wasn't done. So, as you see, he's got diabetes as well, sort of managed, not really. There's the rest of his meds. He's on his Atrovent and Ventolin. And then on Tuesday, I did a spirometry, and you have a look at the result there. So he's got an FEV1 of 1.40, which is 37% of predicted, an FVC of 2.21, 45%, and a ratio of 63. So does all this information add up into the picture of the very large man that you have standing in front of you? It's got FEV1 of 37% predicted. He's 52 and he stopped smoking 20 years ago.
With the eosinophilia, did he know about tuberculosis?
No, that's not a thing. This is more like a trick for young players.
How well did he do his spirometry of the size of his pulpit?
Very good, very good. Wasn't looking, well, I've been expecting more of a restricted pattern, but he's definitely got obstructive pattern. So what are the information So the first thing I did when I saw that spirometry is I went back and had a look at his assessment sheet, which I didn't do, and on smoking history it says stopped smoking 20 years ago. The guy's 52. So what my next question to him was, what were you smoking and when did you start? Started at age 9. Smoked, so this goes into what Jeff was talking about earlier, where the younger they start. And what did he smoke? He's an immigrant to New Zealand. He's come from Samoa, and if you know the Samoan history, they didn't have tobacco in those days. So they smoked Samoan cigarettes. And when I said to him, how much did you smoke? He said, I estimated about 2 packs a day from that time on. He also smoked mushrooms, marijuana, and anything, any plant material he could get his hands on that was not tobacco. So he's going to be in our case conference on Monday, smartening up his therapy. What suggestions are we going to make about medications for him? Does he qualify for Spiriva? Or glycopyrronium? Yep. We're going to go and get his eosinophils, 0.4.
Yep.
Yep. So steroid as well.
Probably the most important thing for him is to lose weight.
Lose weight, absolutely. That's
so
on the agenda.
Whether he's got neutrophilic or eosinophilic inflammation, it's exaggerated substantially if you're overweight. And you can only achieve so much with medications.
Absolutely.
The greatest benefits will come with weight reduction.
So that's already in the agenda for him. But yeah, so I thought I'd just bring that up as one of those times when just asking those next questions, just having a look, does this all add up with what I'm seeing in front of me? It does or it doesn't.
So what other Samoan cigarettes are you talking about? Is it tobacco or not?
No, it's not. It's a plant. I can't remember they call them Samoan cigarettes or Tongan cigarettes or Niuean cigarettes, depending on where you are. I did a presentation for this at Journal Club. The plant is called Mauritian hemp. Now it doesn't have a high amount of cannabinoids in it, and what they do is it's been traditionally grown for years and years and years, and it's endemic through. Well, people can grow it in New Zealand as well. And they pack the leaves on top of one another and roll them into like a cigarette shape and bind it up and dry it. Now, the potency of this particular stuff depends on how much you dry it. And this guy said to me, oh, I liked it strong. And it's something which traditionally has been smoked in the islands. And when, as I said, we don't think it's got a hallucinogenic effect. And I did a lot of research with our Tongan GPs and that up in Auckland. But our lungs were not built to process foreign substances. So I think that's where the damage comes through.